thank you all for being here. I'm always appreciative to be able to join different people. So thank you for that, Dr. Tohen, Don, and the rest of the team.
Hi everyone, this is Rachel, the project coordinator for our Early Psychosis Learning Collaborative. Please feel free to introduce yourself in the chat box. And now I just wanted to review a few housekeeping items with you all before we begin. Next slide, please. Participant microphones have been muted at entry, and you'll be able to mute them during the discussion portion. During the presentation, if you have any technical difficulties or questions about the topic, please use the chat box. And this webinar is being recorded and will be available for viewing at a later time on the MHTTC website. And to reach us after the webinar, you can email newengland@mhttcnetwork.org. Next slide, please. Our team is composed of the Yale Program for Recovery and Community Health in partnership with C4 Innovations, Harvard University's Department of Psychiatry, and the Center for Educational Improvement. Next slide, please. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, respectful, clear, and understandable, and consistent with our actions, policies, and products. Next slide, please. And here's a slide that shows our disclaimers for the National Hispanic and Latino MHTTC, as well as the New England MHTTC. Next slide, please. And here's a list of Dr. Towen's disclosures. Next slide, please. And with that, it is my pleasure to hand it over to Angel for introductions.
Thank you, Rachel. Hi, everybody. Thank you for being here today. My name is Angel Casillas Carmona, and I am project manager for the National Hispanic and Latino Mental Health Technology Transfer Center. For us at the National Hispanic, it's a pleasure to be able to collaborate with Region 1 of the MHTC, with C4, and with all of those that have made this collaboration possible. Today, we will be presenting a webinar focused on first episode psychosis with few of our collaborators from the University of New Mexico that have been developing a curriculum specific for first episode psychosis on Hispanic and Latino youth. Today with us, we have Dr. Mauricio Tohen and Don Hopperin. Thank you both for being here. Without any further ado, Dr. Mauricio, please.
Next slide. Okay, so good morning, everybody, and it's a pleasure for me to be here today. And as you can see on the screen, we have a map of New Mexico. Let me just introduce myself a little bit. So I'm currently a distinguished professor at the University of New Mexico and chair of the Department of Psychiatry. I've been in New Mexico for the last 8 years. And as you can tell from my accent, I grew south of the border. I grew up in Mexico City, and then I've been in different places around the country. I was at McLean, and then I was in pharmaceutical industry, most recently in San Antonio, leading the division of mood disorders. And as I've mentioned, for the last 8 years, I've been here in New Mexico. I always like to, I guess, educate everybody about New Mexico. Couple of things. Number one, it is not new, and it's not in Mexico. So it is, as you can see in the map, part of the US, and it has a long history. Its capital, the state capital, Santa Fe. It is the oldest state capital of any state in the country. It was founded in the late 1800s, few decades before the Pilgrims landed in Plymouth. New Mexico, as you can see, is west of Texas, east of Arizona, and south of Colorado. So there is no wall between Colorado and New Mexico. It is between New Mexico and Mexico. At some point, somebody mentioned that it was between Colorado and New Mexico, but let me clarify that for you. Next. Some facts about New Mexico. As I mentioned, colonized in the late 1500s. It was part of what is known as, or was known as, Nueva España. So it was part of the kingdom of Mexico for at least 3 centuries. In the mid 1800s, so it was part of Mexico. Mexico became independent from Spain in the 1821. So it was briefly part of Mexico, and then with the Treaty of Guadalupe Hidalgo, it became part of the US. And it actually was initially a territory, and it's been a state not that long, actually just a bit over a century. It is large, 5th largest in the country, but it's not densely populated. It is the 6th least densely populated state in the country. As you can see, the population is just 2 million. And Albuquerque, that's where the University of New Mexico is, it's just over 500,000 people. Let me highlight now some very unique facts about New Mexico. It actually, most of the population, as you can see, is English speaking, but almost a third is Spanish speaking, and I'm talking about primary language. And then there's another number of native languages that are spoken. So it is quite unique also that from the point of view of Hispanicity, it is the state with the largest proportion of Hispanics. There's more Hispanics in California or Texas or even in Florida, but from the point of view of percent, 48% of the population is Hispanic. New Mexico is known as a majority minority state because the majority of the population is not of European descent, or actually does not have the Anglo ethnicity. It's another very unique fact is that 10% of the population is Native American, by far 10 times larger than in any state in the country other than Alaska. So it is, from the point of view of percent, the most, I guess, native of any state. It makes it quite unique. I very much love living in New Mexico. It's not like anywhere else. It's almost like an entity in itself. So with that, we have our challenges, and I've been I call myself a student of bipolar disorder and first steps of psychosis. I've been studying both conditions for the last 30 years. And today I'm going to focus, as mentioned, on first steps of psychosis and the unique challenges that we have with treating patients with first episode psychosis, and of course, in our case, with a majority of minority individuals, and as mentioned, half of the population is Hispanic. So doing research in New Mexico makes it quite unique, because our findings can be, I would say, generalized to other parts of the country. So those of you from New England, the percent of Hispanics is certainly much lower. So it would be hard to do studies based or focusing on the Hispanic population. So our goal, well, I see our obligation to be the leaders of knowing the most and with more detail about the mental illness of Hispanics in the US. And as mentioned, today we're going to focus on first episode psychosis. Next. Next, please. So now we can leave the New Mexico one. This is just to, again, emphasize the richness of our state, the Native Americans, the Hispanic, the Anglo. the Anglo community, very, very welcoming state, regardless of your ethnicity, your religion or lack thereof, your gender identity or your gender choice. Very welcoming, very unique state. Next. So this is our agenda. I am aware that our audience, it's a combination of course, health providers with an interest in treating Hispanic patients. But some of you are not psychiatrists, so I'm going to talk a little bit about first steps of psychosis. So those of you who know exactly what is a psychosis, just as just a review for everybody else. We're going to be talking about the initial engagement that we have with our patients, their families, and their uniqueness because of their ethnicity, factors that influence coming to our clinic or not. And then I'm going to Dawn Halpin, she is the director of our clinic. We'll be talking about some of the ways that, or some of the challenges and how we solve them in terms of our Hispanic patients. We won't be doing much pharmacological treatment. There's really no time for that. I will be talking about some uniqueness of Hispanics, but in terms of treatment, including pharmacological, but not specifically reviewing drug X and XY. And then we'll make a summary. Next. Okay, so psychosis, of course, is the perception. And if somebody suffers from psychosis, of course, the perception of the world is different. The beliefs are different. What you see or what you hear is different. And frequently individuals with psychosis also have cognitive impairment. And then what matters most, functional outcomes. Functional outcomes are affected by psychosis. They're affected by the delusions, the hallucinations, and the cognitive changes. So the psychotic symptoms can be divided in positive symptoms, which is hearing or smelling or seeing things that others can't. Delusions, of course, false beliefs, disorganized behavior. So those are the positive symptoms. The negative symptoms, which are unique to a schizophrenia spectrum, is the amotivation, the anhedonia, and as I've mentioned before, cognitive symptoms. Let me just emphasize the point. It is best not to think of first episode schizophrenia or first episode mania or first episode unspecified psychosis. Why? Because at first episode, the diagnosis is unclear. And by the way, the most frequent diagnosis in first episode is unspecified psychosis. And some of these studies that we've done, both here in New Mexico and back when I was in New England, was the stability of the diagnosis. And if you do a diagnosis today, this is of course with structured interview, and then repeat it 2 years later, 40% of individuals have switched diagnosis. For instance, psychotic depression, 40% will change to either bipolar or schizoaffective. So again, the message is very unstable diagnosis initially. It'll switch within the initially, once after 2 years becomes more stable. Next. Okay, so again, think of first episode psychosis along the lines that I've mentioned, the non-affective like schizophrenia and the affective psychosis like mania or psychotic depression. So of course with DSM-5, if it's induced by drugs, it doesn't count. Interesting fact, yesterday marijuana was approved, legalized in New Mexico. So of course we're going to be seeing a lot of that. But actually, if a psychosis is caused by drugs, it'll go away as long as the drug is in the individual's body. So if the person said, "Oh, I used drugs a few days before I became psychotic, but I'm still psychotic," that is of course not drug induced. It was maybe precipitated. Now there's always a prodrome. That means before the individual starts hearing voices or seeing things or having false beliefs, there's actually changes that actually can go back over a decade. For affective psychosis, is anxiety. For non-affective psychosis, is some of the negative symptoms. The young individual will go in the family basement. We don't have basements in New Mexico, but in New England you do. So it starts early in adulthood or adolescence. So key message here: the sooner you initiate treatment, and in this case I'm focusing on pharmacology, the better the outcome. So it's very important to identify when the symptoms start. And there's actually been some studies of treatment during prodrome. We have this program called Connect. I'm sure many of you in the country do it as well, that we start treating the patient in the prodrome. And there's even been some pharmacological studies, but that's the results are, of course, pharmacological treatment causes side effects always, they always do. So you need to, of course, balance. So the message is the sooner you initiate treatment, the better the long-term outcome. And again, the prodrome can be as long as 10 years, but once the first episodes start, you see the delusions or the hallucinations, treatment should start. This is why it is so important to collaborate with law enforcement, because many times individuals with first episode psychosis first come into contact with, let's say, the authorities, with law enforcement for minor things like urinating in public or trespassing, but then they're detained. And in some prisons or jails, they don't provide treatment. So that, of course, will not enable patients to receive treatment right away. So we are here in New Mexico, we have a very close relationship with law enforcement. We educate them, and then when the individual appears to be psychotic, they bring him or her to us. Next slide. Okay, so this, if you can look at the graph, if you see in blue is the different outcomes in terms of functional outcomes. If it's early, it is much better. As you can see, the recovery, living independently actually was not better in early intervention. But that is probably related to does the patient stay home? If the patient is psychotic, depending on some families, it's hard to understand that living independently. But full-time work, the recovery is earlier if the treatment was done earlier. And then interpersonal relations also sooner if the treatment was done sooner. So functioning, quality of life, clinical outcomes improve with early intervention, and costs. Costs are important. We need to make sure that if we have limited resources, we spend them the right way. Next. So coordinated specialty care, as I'm sure you all know, was initiated in New York by Kane. And it is an approach that we actually, there's literally dozens or even hundreds of centers across the country funded by SAMHSA. And the key goal of coordinated specialty care is reduce the duration of untreated psychosis. But to do that, we also need to increase psychosis literacy. What does that mean? It's a little bit of what I did. What is psychosis? We talk to the families, talk to the community, talk to the teachers about what is psychosis and the importance of early intervention and early referral. So when you have your individual with first episode psychosis, could that patient be treated by the primary care provider? Sure. But of course, you want the best possible care, and this is a coordinated specialty care, and it includes a team. This is it's like sports. You play in a team. If you play for Barcelona, Messi by himself can't do it. You really need a team to work together. So it is outpatient, and in terms of the team, we have psychiatrists like myself who will focus on certainly the pharmacological treatment, the overall management of the case, but we also have therapists. Therapists are key. They provide both individual and family therapy, and then we have occupational therapists. Of course, the goal is to return the individual back to work, back to taking care of the children, back whatever they're doing. And it is collaborative. Decisions are made between patient and provider, and it's individually focused. And of course, we promote recovery, resiliency, and shared decision, patient and providers. Next. So in the race study, there was not a lot of findings in terms of Hispanics, because the population, even if the whole race study was almost 400, only 19% was of Hispanic ethnicity. As I'm sure all of you know, Hispanicity is ethnic, not a race. But they did not find that psychotic symptoms were not really related to ethnicity. But here are some of the key findings. Hispanic families were less likely to receive education, psychoeducation. Was it the language? Was it with the families in terms of immigration did not have their documents and they were concerned about going to receive a public service? I would say all of the above. Another finding was that Hispanics, and again, and this is in the race study, they did find that Hispanic patients were receiving more medication management. This is not necessarily bad. What is not good if it's only medication, but receiving medication, of course, is key in addition to the psychosocial therapies. Next. So the different studies here, they found, as mentioned, there's a low level of psychosis literacy. Patients do not seek out patients' sites. And then your third bullet point, key. Most encounters are by law enforcement and involuntary hospitalization. Obviously, when an individual requires involuntary hospitalization, when it is in terms of the non-affective psychosis, it's because the initial symptoms have already been around and the patient was not referred to treatment. Of course, in the affective psychosis, in the manias, they frequently do things that draw the attention of law enforcement, so they bring them to the hospital. And also, it's been seen that the risk of minorities and migrant groups is higher than in the general population. Lots of interesting studies have been done with immigrants. The real answer is depending why they are in this country in terms of the effects of immigration. Very complex. Next. Okay, so now let me tell you a little bit about our center. It's called the Early Center. And as mentioned before, it has a large population of Hispanics. And this is a publication that we just had this year, and we had some interesting findings. Let me go through the findings. What we found is that Hispanic patients who were referred to our first episode clinic, the early clinic where we provide coordinated specialty care, they were referred by mental health providers. Is this good? Is it not? Well, the problem is that they were not referred by families or teachers. And that means that affected the duration of untreated psychosis. It made it longer. So they were referred once they sought mental health care or once they required hospitalization, but an early intervention was not possible because the teachers and the parents didn't educate. The other interesting finding was that those who came to our clinic early were individuals coming from neighborhoods where the predominantly speaking language was English. And of course, this has nothing to do with the language altogether. It's a socioeconomic, but also there's more literature in English as there is in Spanish. So for those individuals who were living in neighborhoods with predominant spoken Spanish, they took longer. So with these findings now we have the findings. What do we do about it? Well, what we're doing is an education of the community and an education in Spanish for those who do not understand English, and we're doing it not only for the community, but also with teachers. So that is our goal now. In other words, to do research and then do something about it. This is, of course, more of a health services research. Let me stop now, and I'm going to ask Dawn Halprin. As mentioned, she is the director of the clinic. She does an outstanding job. And let me introduce my colleague, Dawn Halprin. Dawn, please.
Thank you so much, Dr. Tohen. Okay, so we're going to move into implementation of practice. I'm going to expand upon some of what Dr. Tohen has said, as well as, I don't know, those of you in attendance, if you have not seen Dr. Sandoval's presentation in April, I would highly recommend it. So some of the points that he made, I'm going to also review and expand upon. So CSC, the model that Dr. Tohen talked about, the team approach, very collaborative, physicians, therapists, occupational therapy, case management, peers. It's a close-knit team. And so it might be the model that is suggested, but many places it's not available. So one of the things that I think we'll really go over is looking at some of the things that we learned from CSC and some recommended things, and then pragmatically, how do you implement some of what's recommended regardless of where you're at. So one thing that I want to say from the very beginning is that I don't consider myself an expert in any way related to treating Latinx youth. So this is a tough balance as a clinician, I think, to summarize or generalize how you would treat Latinx youth would be a disservice, but also to say that you would treat everyone who comes in exactly the same is obviously tone deaf, and you'd really need to look at what are some of the factors that folks are experiencing around the country, what are some political, socioeconomic, family, just all the things that somebody might encounter. You have to look case by case and really look to the client and the family to educate you about what their experience is. So being aware of certain areas, but being open and flexible, because the client and the family, they're the experts of themselves. So one of the main things we wanted to talk about today was initial engagement and family involvement. So again, there's no single approach that is one size fits all. There's no such thing as one size fits all. And we're going to talk a little bit about the influencing factors that you should consider and keep in mind when engaging with folks. So who's involved? Ideally, and the person who is identified as your client or the young adult, having that first point of contact be them is really helpful if possible. But like Dr. Tohen has said, many a times folks have come in either because of the police or have been hospitalized against their will. So we're going to look a little bit around, we're going to look at these factors and how it influences engagement with the team and how services are seen by the person. So the individual that is your client, the young adult who has the symptoms, is going to be the leader. And so I say, like, they're steering the boat. And so we're joining them with regard to what they are able to identify they would like to see happen. They're also going to identify who they see as their family or identified supports. We say family, quote unquote, with this model, but family is identified as anyone the young person sees as their support, their support system. So sometimes that's biological, sometimes that's not. So from the very beginning, it's important to kind of get at who's going to be involved in the treatment. Who does the young person identify wanting to be involved? Getting some releases of information, emergency releases of information. Often a person is very symptomatic when they come in, and we want to be able to assist in a way that if we can't get in touch with them, who do they want us to be in touch with? Who do they want us engaging? Who do they trust and want in their care? So going back to my first point is just not being an expert, coming in as a learner, being fallible, being human, engaging with the family and the young person that you yourself are a learner, and being humble with regard to that. So I think it goes a long way to not come across as an expert, and just also identify, you've been working in this field maybe for a while, there are some tools and helpful things that many people have found helpful that you can share, but you are there to learn from them. And cultural competence, I know that's a phrase that we use a lot, and I like to say that it's not something that can be achieved. It's something that you're always striving toward, it's a work in progress. It's a philosophy of how you continue to learn and engage with others and see yourself as a student. Okay, so, and just seeing yourself as a learner. I'm trying to be aware of time, so I want to make sure that we get through some of this. Okay, so who are you, and practicing how you talk about your identity with the clients. So I find that this is a very human approach, and it's not so much you're the one just treating and identifying intervention. I mean, this is, I really like to think about when folks come to us, often can be the most frightening or difficult time in their lives. And so that is not something that we take lightly. It's an honor to be involved with families through this process. And so getting rapport is really sort of getting to know each other a little bit and being open to discussion, and even revealing maybe parts about yourself or identity, being able to have the person comfortable to ask questions, creating the space that they can ask you questions and explore things. One thing I like to think about too when I'm meeting with people is thinking about the history of our profession and the assessments and the theorists, and culturally where that came from. Culturally, who were the theorists? Who were the folks who initially made these assessments? I mean, we've come a long way, but you need to be aware of some of these things when you're sitting down with someone. Biases and assumptions. One of the things that Dr. Sandoval, who, like I said, did a presentation in April, spoke a lot about biases with Latinx, the Latinx population with psychosis, and I would really recommend that you take a look at that. But identity, not static. It's very common for a young person to come into our clinic, and even within the family, for there to be different identity, amongst the young person versus their parents versus their extended family. Some of the things we're also looking at is gender identity, religion, ability, sexuality, age, education, all these things that play in as well, even within one family unit. And does the client consider ethnicity or culture an important area to them? So you'll sometimes really find that maybe the family or the extended family has certain beliefs about mental health, about psychosis, about the goals for the young person, and the young person may not have those same goals. So influencing factors, how was the client referred? So this is all going to influence the perception of care. As Dr. Towen mentioned, many a time if someone has been brought in by police or have been hospitalized, and that's how they come to us, their entry into services probably going to feel a lot different than if someone started to feel a little bit off or a little bit like something was going on and they self-referred, did some research, or called us for information. That's going to look a lot different with regard to how the person sees services, how they see you, how they may engage with you. So you have to be aware of those things. And then always keeping in mind some of the factors that can affect these things as well. Coming out of a global pandemic, we did most of our work has been done via Zoom and technology. Did families have access to these things? How do we bridge some of those barriers? Physical space. What does a family have access to? Is there private space where they are? Are they able to engage? Are they able to get to where you are? Employment, school, legal mandates versus motivation. In this respect, I'm talking about, I think sometimes I hear clinicians say, well, we're trying to engage the family, but the parents haven't come. We've set up appointments, they don't come. And I press on that a little bit with regard to, are they working? Do they have a job that if they left their job, that they would lose their job? I mean, you have to look at sort of the hierarchy of needs and whether it's feasible for someone to engage. So trying to really look at what are individual families dealing with so you can bridge some of those. Now looking at socio-environmental political context, living in a border state, I think New Mexico obviously has some challenges and some things to keep in mind. That might be a little bit different than New York, where I'm from, or Florida, California. So we'll be looking at some of that as well. So this may illustrate a little bit about that. So it's important to think about, are there certain symptoms creating barriers to engagement? So some of that might be, you know, if you have someone come in, they're hospitalized and their delusions are such that they believe that they're being poisoned, they're being harmed, they find medication to be dangerous, and they feel like the mental health professionals are trying to hurt them, that's going to be a lot different than someone, again, who maybe comes in and knows that there's something happening, a little bit of insight to that, and is engaging in care or wanting care. Similarly, then we've got a situation here, which is not uncommon in New Mexico, with experiential barriers that may really prohibit engagement. So here's an example, and we see this example quite a bit. So 17-year-old cisgender Hispanic male referred to us outpatient, brought in by police after a confrontation with neighbor, was paranoid, was agitated. Young man was born in the United States, but his parents are undocumented. Hears voices sometimes, but doesn't go clarify further. Recently lost evening job, stopped attending school. So those are some flags for us with regard to what might also be going on with symptoms. He was open to the referral to our clinic, but he expressed he didn't want his parents involved in his care as he fears them being deported. There have been numerous examples like this within our clinic and other clinics. UNM also has school-based clinics where we're able to bridge some barriers pre-pandemic, be able to go to the schools and assess folks there and talk to folks in school. And there was numerous times where kids were either not coming to school or fearful. ICE was going to schools, or kids were afraid that they would leave school and they would get home to find that their parents were deported. So that's a very real life example of a barrier that what is the engagement like, and what's prohibiting it. So one of the things that I think is really important is to be aware of what the clientele that you're treating might be experiencing and addressing those things, putting them on the table, being able to talk about them, being able to be transparent about what does your clinic, what does your agency do to provide safety with regard to accessing services. What might that look like? So prior to doing any formal assessment, I also like to ask folks about their experience in the past. Have they had any sort of mental health services? What did that look like? What was helpful? What was really not helpful? I tend to really not use a lot of psychological language. I might with some psychoeducation, but then find a way and a common language, avoiding jargon. A lot of the time, I don't even, when I'm talking with someone, initially use the word psychosis. It's a frightening word sometimes for people. So I may later talk about the umbrella of psychosis, but initially really talking about some of the things that people might be experiencing and how they see that and how they define that. So going forward, being able to talk with the person about who is the team, who are we, what do we do, what are our roles, what can they expect? For many folks, this is their entry into the mental health system. For other folks, they've been in the mental health system, but this is a very different, it's either progressed, they've got onset now of different symptoms. So you need to be aware. Sometimes we see acute onset when there's been no mental health history at all, and something has transpired very acutely. And so you want to make sure you're assisting somebody with understanding what they can expect. What are services going to look like, and what are the options for those? Where, when, the type, does your team, will you able to work in the community? Are you able to go into the family's home? Are you able to, what is it going to look like? And so that's important as well. The young person identifying the supports, what does that look like? So who are the people that they feel like are important to be included? Who do they want included? Who do they not want included? reviewing confidentiality and what that looks like, as well as releases and, helping the person understand the parameters of that. This is a question that I like to ask a lot. So whose goals are these? I think that although a CSC program, and I think Dr. Towen explained it quite well with resiliency and increasing function and helping the person get back to what they were doing, I have seen, and I think it's can be easy to slip into if somebody comes into your office or in your clinic somehow and has a certain diagnosis or looks like they've got certain symptoms, to sort of project a goal onto them. So, getting rid of this, getting rid of that symptom. We've had quite a few people who have come through our clinic who really didn't want the psychosis to be completely gone. They have been living that way. They are used to it. They're hoping to either learn some skills or increase their level of control over certain things. So working with the doctor, working with the clinicians around, I don't want this to all be gone. I want to learn how to, I want to be less anxious. I want to be less, the voices don't disturb me. It's not being able to sleep. It's not being able to. So really just listening is the important thing, and getting it. What is the person looking for? So whose goals are they? And they really should be, I think we can ask ourselves that consistently to make sure that we're on track. And then shared decision with prescribers. And Dr. Towen, if you want to jump in with this, by all means, please do. But being able to chat with the doctor ongoing about the process of how the doctor may look at what might be the right medication, what might be the right dose, options and side effects, open communication, things like staying on meds, being cooperative with meds, discontinuing meds, and all of those decisions and factors around that. It's a really important collaborative relationship. Much of the time, the clinician is in support of that. So assisting the person, maybe when you're meeting with them or the family, to identify questions, to identify things that they're noticing. One of the things that happens a lot is sort of a disorganization or an executive function coming undone a bit. So if someone has an appointment with an MD every few weeks or wherever they're at with that, helping them organize their thought process and symptoms questions in order to prepare for appointments. Okay, so before making assumptions, really looking at who does the young person consider to be their family, and are there differences between what the family's expectation is for the young person and what the young person's expectation is for themselves? Are there variations between the family's perception of mental health treatment, of psychosis, of the young person's perception and needs? And so you're really wanting to explore that, and you would welcome having discussions together if the young person is agreeable to that, and being able to discuss those things. So you're empowering the young person in what they'd like to see. There are times when folks will come in and they don't want a lot of involvement with their family, or there's paranoia toward the family, there's some symptoms there. So our team will look at a clinician working with the young person and potentially another clinician, just providing psychoeducation to a family about what might be going on, supports, and then just the support of the family. So we look at the needs of the family and figure out with the different people on the team how we might best support. Okay, so addressing language. If the client is bilingual, never ever have them in the role of the interpreter. I know that there are times in certain areas where has happened. It's really important to make sure that the person who is the client is receiving support and not providing the support to others. So this results in just a real shift in dynamic, miscommunication. Sometimes it's purposeful, sometimes not, but it's a really difficult thing to maneuver. Considering language proficiency before assuming symptomology. So there are times when, there's a whole language and lexicon that we use around these symptoms. And so it's really difficult for folks when you're experiencing something new to sometimes articulate or have the language for what they're even experiencing. Or, we'll get into some stuff with interpreters and whether or not the interpreter has certain language within clinical language that you're utilizing, and some of the barriers that there might be with language. So considering where's the proficiency, where's the psychosis literacy with regard to what we're communicating about. It's interesting because there are times when I've worked with clinicians who speak Spanish, but they don't necessarily have clinical language, or they've studied Spanish and they are conversational. But that doesn't mean that you don't need an interpreter, or that doesn't mean, so these are factors that you really, really need to think about. And then thinking about using interpreters and things like, the person might be experiencing sensory distortion, feels like time is slowed down. Is that something an interpreter can articulate? So we're going to go through some of the things with regard to working with an interpreter that, if you can do, would be wonderful. And so we're limited in some of this, but doing the best we can with bridging some of these things and being aware of some of these pitfalls. Sharing a language does not always mean sharing a culture or having a contextual knowledge. So, a person who is from Mexico, a person is from, it doesn't necessarily mean because somebody speaks Spanish means they understand their culture. And so it's an important factor to think about, and the differences in culture, even with maybe a clinician and a client who speak fluently. And sharing a language doesn't negate the need to clarify or confirm understanding. So we'll get into a little bit more about that, specifically with using interpreters, because I know it's an issue that folks have had a lot of questions about. So native speakers might be more accepted by the family, or it feels like there may be more connection there. But also I've seen clinicians that speak Spanish that will use an interpreter, but also try to speak Spanish a bit, or be able to bring in an interpreter to say, I speak Spanish. I want to make sure that this is making sure that you're doing a good service, making sure that you're communicating to the clinical degree that you need to. And so not just assuming that you speak Spanish and so you're fine to practice clinically. Interpreter services, it can be a barrier to rapport when you think about potentially going into a situation and not feeling well, and all the things that might go with that fear, and this is something new, and meeting a new person and being asked a lot of questions, and then there's a third person who the flow then becomes off, and it can feel very different. Interpreters might not have the emotional contextual knowledge. If reviewing confidentiality, but having another person there, it can change how things will feel for the client. With regard to maybe Zoom, or if you can only get an interpreter over the phone, you're missing body language and other cues that may be difficult. And interpreters might have difficulty conveying certain concepts. So one of the things that I think is really important, if it's feasible to do this, is to be as prepared as possible. So if you know who the interpreter is going to be, it would be great to build a little rapport with that person. If this is someone who's going to be working with you in some context, maybe providing psychoeducation to them, talking about psychosis, giving them a little bit of framework just in general. Making sure that you are, you can even test out a little bit. I know that Dr. Sandoval had mentioned sort of having a summary of something and doing like a translation and having it interpreted by the interpreter, and trying to work with that a little bit prior and prepping yourselves. Being able to speak to interpretation dynamic and put it on the table. I'm a proponent of just really having a transparent process. So even though it really is the interpreter saying exactly what is said by each person, I think it's important that the client knows some of the barriers there, or what to expect, and that they can jump in to question what's been said, or if they feel like they're not being heard, a lot of times there's a hierarchy there with regard to seeing the interpreter as, you know, an authority figure. And so really putting it on the table, you want to really balance that hierarchy as much as you can so that a person feels comfortable, feels like they're understood, and what they're trying to articulate is being described. So some things as well, being able to start dialogue. And so I think talking about culture, it's important to just start to get to know somebody. So some of the questions that you can ask, if they're not specific to their ethnic identity, but what's important for me to know, and how were you raised, and what are some important things to your family, or do you have differing views than your family about X, Y, and Z? And so exploring some of that. One of the things that I did want to talk about as well is Dr. Sandoval in the last presentation had spoken about someone who he was assessing, whose primary language was Spanish, and Dr. Sandoval's primary language is Spanish, and offered to do the assessment in Spanish, and the person had insisted on speaking English for the assessment. And so, you know, there was sort of a question there, but of course you're led by the client, and so they proceeded. And so he's doing the assessment. I think at one point the person leaves to use the restroom, comes back, starts speaking in Spanish. And when the person starts speaking in their primary emotional language, that's when he started to see the symptoms and assess the symptoms of what was going on. So the distinguishing between primary language, emotional language, and maybe you speak a language, but some of that can get lost with regard to the person even interpreting and translating what they think into another language. So the person was able to compartmentalize and contain that process for themselves, but not in their primary language. So one of the things that I wanted to talk about was utilizing that as a tool. So one of the things that I do with folks is, here's an example. There was a young man I was working with whose extended family speaks Spanish, but he was raised speaking English and did not speak Spanish at all. He wanted to get back in touch with his roots and was learning Spanish. So he wanted to learn Spanish, but his emotional first language is English. And so when he would be really symptomatic, one of the things that we utilized was actually reading in Spanish, and switching, having his brain switch to that kind of focus, and what he was trying to learn or read was enough to quiet things down or blur those edges a little bit. So he was having pretty strong auditory hallucinations. He had started to work. There were other things going on. He was working very closely with the doctor around medication, but we were trying to find these strategies that he could, you know, manage some of the symptoms that he was having. So we actually had like books on his phone that were in Spanish. And so he may be riding the bus or doing other things, and symptoms getting bad. As soon as he started reading Spanish, for him, it was a little bit like it sort of blurred it enough and brought it down a little bit so that it was a little more manageable. Didn't make it go away, but we found these strategies to sort of blur the edges so that he could get through those moments. So there's an interesting play with regard to emotional language, learning a new language, or how the brain concentrates on certain things and how you can use those as strategies for folks. Okay, so let's go into cultural expression versus maladaptive symptoms. Do not pathologize culture, and looking at what is the person experiencing that may be cultural. Maybe where does the cultural aspect of something end, and where does the problematic stuff begin? So you're looking to the person and the family to identify some of this for you. Developing a common language. So going through auditory hallucinations and visual hallucinations. And typically when I'm working with folks, they are using some other language for themselves. So I worked with a young man who had voices, different voices, one group of which he called the narrators, and another group he called the I think it was the robots. And so there was an artificial intelligence, persecutory stuff that was going on for him, and those were the robots that would, the narrators were just kind of the more benign voices that would happen, that would just narrate what was going on, or whisper, that's true, that's false, things like that. They were less distressing to the person. So when they would come in each week, I would ask what's it been like with the narrators this week? What's it been like with the robots this week? Because that was the language that he spoke, and he could articulate the two different kinds of hallucinations that he was having. Sometimes when I'm chatting with people too, in assessing people, a lot of times there's not a language for folks when you're experiencing something new, and language can really fall short of things. So sometimes what I like to do is to not assume or even ask direct questions about things if someone is looking fairly uncomfortable, but just to normalize. Some folks that have come in, or many folks, describe this. This might not apply to you, but this is some stuff that I have heard over the years that people experience. So you're normalizing some of what someone might be experiencing, and you're creating the space to kind of talk about some symptoms, but also that you're sort of aware of what they might be going through. Here's another, I know we're running out of time. This is another example, I think, that looks at culture and want to look at where does something that is a gift or culture, where does that start, where does that end, and where does symptom begin? So this is the story of a young person that we treated with some stuff changed, of course, for confidentiality. 19-year-old Hispanic female came to the clinic at the urging of her aunt and uncle with whom she lives. Sophia's aunt explains that Sophia's always been really sensitive, and she's communicated with her abuela, her grandmother, who passed away when Sophia's mother was pregnant with her. Gathering information, we learned that the family sees Sophia as having a gift, since she's always been able to communicate with the grandmother. She's been hearing her grandmother's voice since she was a toddler. It's been comforting, it's not been distressing, and the family has looked at this is a really wonderful thing. Recently, Sophia's family notices that there are changes that are concerning to them. She's agitated, she's stopped socializing, her grades have dropped. And so we can assume too that however these folks got to your office, they're help seeking because there's something that's transpired that isn't comfortable or is distressing. So point that I want to make with this is you're not going to look at the fact that Sophia hears her grandmother as being a symptom. That's not a symptom. What we're looking at is for the family to identify what the change was. So where is the change? To ask more questions about this, I was asking about what they've noticed, what's concerning, right? She's agitated, she's not socializing. So come to find out she's in her room a lot. Her grades have dropped. She comes home from school. She was had falling out with friends. She thinks that friends are against her. Pressing a little bit more about what they're seeing around the house. She has difficulty watching TV because she feels as though there are some messages coming to her. At one point, she was taping pieces of paper over the eyes of pictures of the family and other pictures that are in the house, photographs, because of thinking that they were looking into her soul or could hear her voice and those kinds of things, could hear her thought process, I'm sorry. So one of the things we started to look at is the family identifying where the change has happened. So when the family identifies, okay, so right now she's agitated in this and this and this, but like last year, her grades started to slip, or we noticed she wasn't engaging with family very often. She was isolating more. We're looking at some prodromal stuff potentially, right? But we're also looking at when she's taping the eyes of photographs in the house and can't watch TV, every so often she would start yelling, "Did you hear that? Did you hear that?" And she's distressed. So the family comes in for help. So what you're looking at is where the change has happened. And where the change has happened is not hearing the grandmother's voice. It's way later. It's when she starts to isolate, when her grades start to plummet. We're seeing a decrease in function, when she's starting to have symptoms of distress. So that's the onset. And so being able to then work with the family around prodromal symptoms or something that we can sort of retro look at and say, this might explain what was going on at that point. But, folks who have some of those symptoms, it averages about 30, I think they say 33% will maybe convert to a primary psychotic disorder. So that's why some of those programs for clinical high risk is to provide care there to hopefully get things under control. Possibilities the person might not convert and meet threshold for primary psychosis. But one of the things you're looking at then is identify where the change, where's the distress, what are the goals, and engaging the family at that place. So just about at 10 o'clock, I know I kind of flew through some of that, but if there are questions, we can field those now. I can't see the chat, so I don't know. I mean, if someone does have some questions, if you want to just unmute yourself, or I know the folks assisting us have been sort of monitoring the chat, so.
Thank you, Don, and thank you, Dr. Mauricio Tohen. We have some people that wanted to ask questions. It seems that they can't unmute themselves. I don't know if Vanessa could help us out. She already wrote the person. Carmen, if you could unmute yourself.
Now I can.
Welcome.
Thank you. I just have a comment about interpretation. I am a medical interpreter for about 15 years. And when you're working with a good interpreter, the interpreter should be able to, in doing medical interpreting, you are able to advocate for the person as well. So if you see that the face is blank, that they are not understanding, a good interpreter would ask questions and try to make sure that the person is understanding what is being said. So the interpreter is not only to interpret word for word, but as well as if there is any lack of language or any barrier, we're there to make sure that everything is understood.
If I can add a comment there. So as mentioned before, with the large number of individuals in New Mexico who don't speak English, there's issues with translation. And we certainly had a big complaint from a family. This was an undocumented family who didn't speak English. And then the Department of Health came to talk to us. And it was actually after that, we don't allow individuals who are not certified interpreters to do the interpretation, because this is, of course, it has its very clear skills. And for that matter, if a clinician kind of speaks a little bit of Spanish or things that she or he does, they should use an interpreter. The other thing, we don't use other clinicians as interpreters. Sometimes people would ask me, oh, can you interpret? I said, no, for two reasons. But the first one is that I'm not a certified interpreter. So you have to be a certified interpreter to be able to interpret. And myself, of course, Spanish is my primary language. I obviously do not need an interpreter, but unless that is the case, that you're fully bilingual, it's always the importance of having a professional interpreter to do this. And again, this caused some issues. So now in our medical record, we have to indicate what's interpretation needed, and was it done by a certified interpreter? There's no other way to do it.
And I think it's also a good idea if the interpreter has a little bit of information prior to a session, so they can check themselves to see if they know all the language and ask questions to make sure that they are on the same page with the clinician. Sure.
As Don mentioned, it's important to have a, let's say, bond between the clinician and the interpreter. And as you mentioned, Madam Interpreter, that there should be a conversation about the case. Yeah, definitely very helpful, especially in our field. Now, the case that I was referring to had to do with a blood transfusion, kind of a very complicated medical case. But in our cases, we work with our language. That's where it's very, very important, as opposed to if you were just, I guess, doing orthopedic surgery or what have you. Other comments, folks? Let me just mention, I want to thank our hosts, and hopefully we'll be invited back and actually share our results or challenges in the Hispanic population as New Mexico, and hopefully some of our findings can be generalized to the whole country. So thank you all for joining us today. Dawn.
Thank you. Yeah, thanks everybody for coming. Did anybody else have questions or comments or?
I got a question for you guys. Do you hear me?
Yes.
Perfect. Are you guys able to provide, share the information about the PowerPoint presentation by any chance? Will you be able to share this information?
Absolutely. I believe Angel, this will be available to everyone, correct?
Yes, we will be sharing both the recording and the PowerPoint in English, Spanish, and Portuguese in our webpage, so everybody can have access to that during the next week or so.
Awesome. Thank you.
Also, I would like to move your attention to the chat where we have posted our evaluation. For us, it's very important that you help us out with what you think of this event. This is what allows us to continue to provide training free of charge through our SAMHSA grant. So for our colleagues at Region 1 and for our center, it will be much appreciated if you could help us out with the brief survey that you have in the chat. Once again, thank you all for being with us today. I don't know if Rachel wants to mention anything, or Raquel at the end before we excuse ourselves.
Yeah, thank you all for attending today's webinar. And as Angel said, we'd really appreciate if you could fill out the survey form.
And I just wanted to add my thanks to both of you for this really wonderful, very informative presentation today. And the only other quick question that I had, and maybe it's something that can be sent out later, was about whether there might be any resources, tools, or websites you might recommend that way to help us to continue to build our cultural competence in working with individuals with early psychosis in the Latinx and Hispanic communities.
We certainly will, and also make available our publication where we focus on the challenges of access to coordinated specialty care. Thank you again, folks, and thank you to our hosts. Dawn, terrific job. Thank you.
Thank you.
For all those folks, I have shared a brief resource of our webpage where you can find some materials on early psychosis from Dr. Tohan and their team, and be on the lookout for new materials that we'll be developing. Thank you.
Thanks so much.
Great. Thank you all.